a couple of points of data of some of the current things that are going on. Branched endografts for iliac disease are not really in any of our present at the moment to too much extent, but this is from Dr. Cow's group in Italy. And in the first group, which is the branched group, versus the second group, which is internal iliac occlusion, there was no difference in mortality, or there were no mortalities in either group. Procedure time was nearly identical. Not surprisingly, fluoro time was slightly longer in absolute terms with the branch grafts in group 1. Contrast was essentially similar. Technical failure was similar. External limb occlusion was similar. Iliac endoleak was higher in the group with coil embolization of the internals, and really there were not a huge number of other differences in these groups. The one-year results, likewise, they found very little difference with the exception of pelvic ischemia, rather, related to, obviously, to the internal iliac embolization in the occlusion group. So this was the main difference between these groups, and obviously branched grafting for this maintains pelvic perfusion is a little more physiologic. So that's something to keep in mind in the future. Coils versus plugs, one of the analyses that are out there, comparisons between cases done with nitinol plugs and coils. Similar, this is a small analysis obviously, but about 20 patients in each group. Similar age, similar gender distribution. They found cost difference in this small set. There was approximately a threefold difference in cost with coils. About 8 devices used versus about 1 device used in the plug cases. And key here being that the buttock claudication rate was much lower in the plug group. And we've talked about this in our conference recently here in Charleston, and one of the points that was a consensus, I thought, was that this is likely due to better control of where you're able to land this. You're not as likely to do a slightly more distal embolization or non-target embolization out in one of the anterior posterior divisions, and you have a little better control, and obviously with the plug than with at least non-retrievable coils. A couple of quick other options that are things to keep in mind, at least until we have branch grafts more routinely. The so-called trifurcated graft. This is a paper that Minion at Kentucky has out there about this technique. I've not done this. I've had a patient who's forwarded me their films from a similar technique who approached me about taking care of them while I was in transition here from Rochester, but they had it done up at Columbia. And so I unfortunately don't have them to share with you today, but I've seen this done in a patient who's known to me with some success actually for an iatrogenic iliac arterial aneurysm, but the main point being that you can build a graft within a graft with a small main body in the side that you're going to preserve the antegrade perfusion on. You need to coil one internal on the you need to take out one internal iliac on one side, and then via a brachial approach you can put a covered stent graft down into the via stent graft approach you can put a covered, and via a brachial approach you can put a covered stent down into the internal iliac on the other side. Obviously maintaining orientation of that contralimb on the second main body that's going in between C and D is pretty critical. Another quick, but I think more and more, especially with the other options we have for this and that are emerging, is going to more and more move into a footnote historically, but I have used a couple of times with good success in a couple of people and in other people that didn't have options really at the time. But the retrograde hypogastric artery perfusion, or essentially a covered stent going from the external to the internal. Technical points with that, I would think, are that it's best in patients who have a rather obtuse angle rather than a very acute angle between the internal and the external, and that you're able to maintain perfusion. There is a lot riding on things that let us down from time to time in vascular surgery, particularly their fem-fem. So in somebody with, particularly with a lot of occlusive disease, you really want to make sure that they're fem-fem crossing from the other side to this. And this is, of course, from Hodgson's group at SIU with anatomically entertaining diagrams, but essentially a aorta uniiliac reconstruction down one side, and a fem-fem going to the other side, and then a covered stent maintaining perfusion to the internal iliac but excluding the aneurysm on that side. Obviously, if this fem-fem goes down or this covered stent kinks with this other side covered, there's a setup for a fairly profound pelvic ischemia. If it's due to the failed fem-fem, there's an option to fix it. If it's due to the covered stent, it's going to be a lot longer to fix that. Just one quick case presentation. This is a 78-year-old gentleman who was on Plavix. He's had 3 MIs in the past, drug-eluting stent, COPD, home oxygen, existing prosthetic distal bypass on his right side that has been has had people back in it twice already. He also initially had a common iliac aneurysm on that, or common femoral aneurysm on that side. He came into us Thanksgiving here with a symptomatic abdominal aortic aneurysm. His pain resolved, improved with blood pressure control. His creatinine was 1.4 to 1.8 at baseline. We felt like he needed a contrasted exam to try to figure out if he was an anatomic candidate for an endovascular repair. I did not think he was a very good candidate for any sort of open approach given the information above and just looking at him. EVAR, we elected to do an EVAR with an internal iliac plug on the right. We did this mostly with CO2 and 42 cc's of contrast. He was extubated on arrival at CT ICU, or extubated in the OR, brought to CT ICU, and went home on day 5 back to his baseline creatinine. This is his pre-op CTA, reconstruction of his CTA here. You can see there's an iliac aneurysm that came down into the external on the right, and there's a small internal iliac artery on the right. You can see stranding here in the retroperitoneum, so obviously we were compelled to take this pretty seriously. And unfortunately, due to the fact that I was using very little contrast when I did this, I mostly have a follow-up shot to show you, and that's about it. This was a much more impressive internal iliac. It's obviously taking off behind. I did go from the left with our balloon occluder for this, or sorry, I went from the left with our plug occluder for this, and of course was thinking about the comments I was making before about how there's never a great side in some of these cases. Cross the limbs, and this is a single shot completion, and that's excluded. Obviously, lots of confusing with so many of these things, either paucity of data or confusing data, and lots of different options. But again, just to review, retain one iliac. When not possible, consider staged bilateral internal iliac occlusions. I know Alex DeBona and Jay Robeson here in Charleston at the VA managed somebody recently who's been back to clinic who's now had both taken out over the course of about 2 years. They were intervened to get a better seal on the right, and he is without claudication and without other symptoms and is doing well. We're following at the VA. So stage when you can, coil plug, covered stents to do some sort of retrograde maneuver with a fem-fem, iliac branch devices when they come along, or a fabricated branch device or one of these trifurcated repairs. Stay as proximal as possible in the internal iliac. Pelvic ischemia and buttock claudication and impotence are all things that should be discussed explicitly with the patient. And obviously, if for no other reason than discussion with some of these people, obviously addressing surgical alternatives and getting that on the table is important. And take any questions.